Dr. Shaheen, are you ready?
Yes, sir.
So, one, two, three, and start.
Hello, good evening.
Good evening, doctor.
I'm Dr. Beth, one of the doctors in clinic. Are you Mr. Albert, 24 years old?
Yes, doctor. I'm Albert, 24 years of age.
Yes. Today we are here to discuss about your medical problem and I will examine you. Is that fine?
Okay, doctor. Please, thank you.
You came with problem of fainting attacks. Please tell me more about it.
Yes, doctor. It is really astonishing. I was quite fine, but from the last 6 or 7 months, I am having repeated fainting. It happened yesterday. Last time yesterday afternoon, I was waiting in a queue to pay the bills in a grocery store, and it happened there.
I'm sorry to know, Mr. Albert. We'll help you in this regard. You said in the past 6-7 months, how many times it has happened?
2 or 3 times, doctor.
Okay. And anything make it worse, like you said, standing in the queue. What about the previous episodes?
Yes, doctor. Last time I was standing in a queue again to pay my bills in a bank. So most of the time it happens when I am standing.
Right. And anything making it better?
Doctor, I haven't noticed anything.
Okay. Along with this faint, do you have any other problem like weakness of any part of the body?
No, doctor, I don't have any weakness. Though after the faint, I feel weak for a couple of minutes.
Okay. Before this fainting, do you feel any symptoms of abnormal sensation or abnormal vision around the eyes?
No, doctor.
Okay. Any during this, any tongue bite or any urine or feces in passed out?
No, doctor, never.
Okay. And were you losing consciousness during this episode or were you aware of the surroundings?
No, doctor, I haven't lost consciousness during all these attacks.
And any numbness or any tingling in any part of the body?
No numbness and no tingling, doctor.
Okay. So you said after episode you feel weak, right?
Yeah.
What type of weakness? Is this like a whole body weakness or any part of the body?
Doctor, I feel like lack of energy, low energy. I feel I'm very weak, lethargic.
Okay, like whole body you feel weak, right?
Yes.
Okay. During this episode, do you feel any chest pain,
No, doctor.
any shortness of breath,
No, doctor.
any racing or pacing of heart?
No, doctor.
Okay. Right. May I know anything in the past I should be aware of?
No, doctor. I was quite fine. I was just doing my regular life. I don't know what happened.
Any history of high sugar, high blood pressure?
No, doctor. My mother is diabetic, but I'm not.
Okay. Any family history of sudden death?
No, doctor. Really not.
Okay. You said your mother diabetic, right?
Hmm.
Okay. Any any history of cardiac illness in the heart problem in the family?
Doctor, I don't know any such problem. I think everyone is fine.
Okay. Mr. Albert, may I know, are you on any medicines recently?
Doctor, I have started to take some multivitamins over the counter because I think maybe they will help in the weakness. Otherwise, I'm not taking any medication.
Okay. I'm sorry to ask, Mr. Albert, but do you take illicit drugs?
No, doctor.
Okay. Any herbal medicines?
No, doctor.
Okay. Okay. I want to examine the patient.
Sure. What do you want to examine? Tell me the steps.
Yes, I would like to check pulse.
Pulse is 72 beats per minute, regular in rate, rhythm, volume, character.
Okay. Blood pressure is also regular.
120 by 80.
Yes. I want to check carotid, the bruit in the carotid.
You want to check the bruise straight away, or you want to feel the carotids in the
Feel the
beginning?
carotid. First, feel the carotid. Is there any?
Okay. No, the carotids are normal.
Okay. And bruit also absent.
Yeah.
Okay. Then chest, any murmur?
No murmur at all.
Okay,
The
I want to
patient
check.
cardio is normal.
Okay, and I want to ask any abnormal rash or pigmentation in any part of the body.
No, doctor, no rash and no pigmentation.
Right. I want to check the weakness, any part of the body. Check the power in
No,
the proximal muscles. Is it fine?
no weakness, no weakness.
A pronator drift, I want to check.
Pronator drift. Okay, it's fine. No weakness, no pronator drift.
Okay. May I know, Mr. Albert, do you smoke?
Yes, doctor, I do smoke 5 cigarettes a day from last 15 years.
Okay. Smoking is injurious for you, and I will advise to quit smoking. We can help you by referring to smoking cessation clinic. Do you drink alcohol?
Mhm. No, doctor.
Okay. Um, right. I want to examine the patient reflex planters.
They are fine.
Okay. And
Anything
and
else you want to
postural,
examine?
yes, postural drop of blood pressure.
Very
There is.
good. Okay, you have 1 more minute, but there is no postural drop.
Okay, Mr. Albert, what are your concerns?
Doctor, I'm really afraid. Do I have fit epilepsy?
Mr. Albert, I appreciate your concern. After examining you and taking history, I don't think you have any seizure or any fit. You are suffering from a condition what we call as vasovagal syncope. I will explain you in this. There is a lack of blood supply to some part of the brain for some time, due to which
Hmm.
you feel weakness and you fall down because of this vasovagal syncope, because
Hmm.
the heart, the pumping action of the heart is disturbed, and there are many factors affecting it, like standing for long time in hot weather, as you were standing in crowd. So I would like to advise you by taking some measures, not to stand in crowd and in hot weather for long time, and take plenty of fluids, right?
Okay, your time finishes, but you can carry on. No problem.
Okay. Avoid crowded places, or avoid any heavy sweating or
Hmm.
heavy closed environment. These are the
Hmm.
conditions which aggravate it. So, and we will
Okay.
help, will guide you about this, and take plenty of fluids.
Hmm. Okay, doctor. Thank you very much for your kind and nice performance. Very well done, Dr. Shine. But may I know what is your diagnosis?
Yes, sir, first diagnosis is age of the patient 24, sir. There were no cardiac, no neurological symptoms. So my first diagnosis is vasovagal syncope.
All right. So, very well. How are you going to investigate?
Yes, sir. Apart from basic investigation, we will do the postural hypotension blood pressure, which was not present, and we can do tilt table test,
That is something we
differentiate
don't.
to differentiate from in order to rule out reflex syncope. But for vasovagal, the diagnosis is clinical, and we can do blood pressure monitoring, like ECG. We can do ECG, echo,
Very good.
24
Very
hours.
good.
Yes, 24
Uh,
hours ECG monitoring and Holter monitoring. And loop
um,
recorder we can do for ruling out any cardiac event, but in this case there were nothing cardiac symptom, but we can do this for ruling out other cardiac causes, and for reflex we can do tilt table test.
can you please tell me the two the two most important investigations which you will do in this patient?
Yes, sir, 24 hours ECG,
Okay. Other one,
and sir
tilt
Doppler
table test.
tilt table test, sir. Yes, sir, tilt
Okay.
table
How are
test.
you going to manage?
Sir, we will advise non-pharmacological management, like avoiding crowded places and avoid
Hmm.
hot weather,
Hmm.
and closed environment avoid, and plenty of fluids, and yeah, prolonged standing should be avoided. And
Okay.
uh,
All right. Anything else? Any referral you would like to give the
yes, sir.
patient?
So for referral, in the follow-up clinic, I would like to refer patient again follow-up after like some 1 week with all the
Okay.
investigation.
Okay. All right, Dr. Shine. I think you tried your best and you reached the diagnosis. So let me tell you a few things about your performance. Then we can discuss the case as a whole.
Yes,
First
sir.
of all,
Thank you.
Dr. Shaheen, no problem, it's okay. Please keep the introduction short. In station 5, please keep the introduction short. You only have 8 minutes. We can't afford to have a very decorated or very good sort of introduction. Keep it a short, like, hello, Mr. Patient. Like I used to say, hello, Mr. Patient. I am Dr. Bukhari. I'm here to talk to you and examine you. Is it fine? He will say, definitely, it is okay. Then please tell me what brings you to the hospital. Just keep it short. Hello, I'm Dr. Bukhari. I'm here to talk to you and examine you. Is it okay? Okay. So please tell me what brings you to the hospital. Anyways, then uh, there are some words like urine and feces. Urine is okay, but at least don't use feces in exam. It's not so well spoken word. Um Never say illicit drugs. Do you use any illicit drugs? Be more polite. You can say, do you use any drugs or anything for recreation? Or are you using any party drugs?
Yes, sir.
Illicit drugs is very offensive. Please be careful. Um, Whenever cardiac death is a jargon, cardiac is a term which we know more common, but other people don't know what is cardiac. Maybe nowadays they know. They are more literacy rate is all over the world is improving, but for exam purpose, always say heart problems. Anyways, and when the patient gives you, there are few symptoms which can come repeatedly, like these attacks, and patient is telling you very clearly that he had multiple attacks. So in that case, whenever the patient gives you any symptom that can come repeatedly or that is coming repeatedly, you must ask, when was the last attack, and was this attack similar to the previous one? I mean, you must judge or you must take an idea that is there any change in the symptoms, recent change in the symptoms, because it is usually a red flag. The change in the nature of symptoms is usually a red flag. So whenever you have any symptom like fall, like headaches, like palpitations, any symptom which has a tendency to reoccur, you must compare it with the last one, to get an idea that is there any change in the nature. Anyways, it was a good performance overall. Uh, Whenever we have, please remember that fainting attacks, dizzy spells, blackouts, fall, they are approximately the same category. And whenever this happens, you get this symptom, you will divide your history into three headings. Okay, before the symptom, during the symptom, or before the attack, during the attack, and after the attack. So keep it as a whole, generally three headings. And then, uh, you know, attacks, faintings, dizzy spell, there are some things which the patient can't tell us, because the patient is fainted, has lost consciousness, he is having fit, whatever. So collateral history becomes very important. So you will ask, was anyone accompanying you at that time? Collateral history is very important in TIA, in stroke, in fit, in fainting attacks. The reason I told you the patient can't tell everything about themselves when they are down. So you will ask, was anyone accompanying you at that time? Then uh, you will start before. What were you doing exactly at that time? And believe me, if patient is sitting, it will rule out vasovagal syncope, at least for exam purpose. Syncope will definitely occur in standing, at least for exam purpose. So what he was doing exactly at that time, which time of the day the attack was he feeling hungry, any unusual feeling before the attack, like Dr. Shine asked about chest pain, racing of the heart, sweating, dizzy. Uh, One very important question you can ask about, Do you smell abnormal or do you see any zigzag lights? This means aura. The patient is having aura, which may be pointing towards a fit. Second thing, you can ask about any severe chest pain, any racing of the heart. It may point toward the cardiac causes. You can even ask, were you doing any exercise? I mean, when you will ask that what he was doing exactly at that time, so he will tell you, I was doing exercise. Anyways, it will point toward the cardiac causes. So then, did you remember falling? Did you remember that you fell down? I mean, the loss of consciousness. So then, during the attack, if someone was with her or with him, so did anyone check your pulse at that time? Did anyone check your blood pressure, blood sugar level at that time? Did you lose consciousness? And any abnormal or jerky movements? This is very important question because without asking abnormal or jerky movements, you can't rule out at least fit, at least for exam purpose. You may add on any color changes. If the patient gets paler, it points towards syncope. If the patient gets blue cyanosis, it points towards epilepsy, fit. And then definitely, did you injure yourself? Did you bite your tongue? Any loss of control of waterworks or bowel works? So during, now after the attack, how much time the attack lasts? The rapid onset, rapid recovery, mostly it is syncope. The, I mean, the prolonged recovery, fit. It points toward the fit. How you regain consciousness, and then any weakness or any problem in your speech when you regain consciousness. The patient may give you history of torts, paralysis, or slurriness of speech. That will mean the fit. The patient may give you whole body weakness. That is syncope. No issue. So in this way, you will demarcate your history. And please remember, when the patient is young or old, anyone, in fall, we are more concerned to rule out cardiac causes, especially in young patient in this age group. Certain cardiac issues like Hockham, long QT, Brugada, these things. So we have to ask specifically any history of sudden death in the family. That is very well. You can even ask a few red flags if you have time. You can ask few red flags of heart, cardiovascular system, like any orthopnea, any swelling around your ankles or orthopnea, to show the examiner that you are considering cardiovascular system. The syncope most likely comes when the patient is standing for a long time in hot weather, ambient weather, you can say, when there is feeling of apprehension. Some people may see blood. Some people may hear noises, and they may have syncopal attacks. And if someone is tired, someone is even having lack of sleep, they are more prone to have syncope. Anyways, this was syncope, and our main concern was to rule out cardiovascular causes, which the man denied. So medication history is important. Recreational drugs sometimes they can cause. You can ask about driving. You forget to ask about driving. Driving is important. Um, Hobbies may be important because if the person plays football or any aggressive hobby, he should take care. So never miss hobbies. Regarding the driving, overall, the patients who have vasovagal syncope, and if they have class one license, they can drive. Okay, I will repeat. The people who have vasovagal syncope and they have class one license, I mean their own personal car, they can drive until and unless They know their triggers and they can avoid those triggers. Whereas the people who have class 2 license, they can't drive. They must inform DVLA. So if you will ask this gentleman, he will tell you that he is driving his own car and he can drive. Not a big deal. Okay, examination. As I told you that the whole purpose is to rule out any cardiac abnormality. So you should do a good cardiovascular examination, and you did well, starting from the pulse, then carotids, then definitely feel apex beat and auscultate the heart. Um, Whenever patient has a fall, either vasovagal or fit, you must open the mouth. Ask him to open the mouth and see his tongue. This will indicate that you are worried about tongue bite and you are worried about patient welfare. So always check the tongue bite and the tongue. And you can check pronator drift, not a big deal, but the most likely and most important examination is CVS. Okay, vasovagal syncope. How you will explain? You will tell to the patient that there is somehow problem which results in the pooling of the blood in the blood vessels of your leg. When you stand for a longer period of time, the blood gets pooled, pooling of blood in the legs, and there is reduced blood supply to the brain and to the heart, and you feel dizzy and you fall down. It is transient. As soon as you fall down, the blood supply is regained and you can carry on. So basically, there is problem with the pooling of blood. And investigations, NICE recommends that at least every vasovagal patient having vasovagal syncope should have 12 lead ECG, 12 lead ECG, and tilt table test, though not routinely done, but you can add on. And every patient with fall, I will suggest do the blood sugar levels and serum electrolytes. So 12 lead ECG, tilt table test, and serum electrolytes and blood sugar levels if you want to add on. No need to do echo, no need to do Holter monitoring if the diagnosis is clear cut. Okay, if the diagnosis is vague, history is vague, or there are certain features in the history, like sudden death in the family, then definitely that is a different case. We need to probe further. We may add on echo and whatever. But in this case, pure syncope, at least 12 lead ECG tilt table test. Treatment, uh, you mentioned well, you can reassure the patient that treatment that it is a benign, simple condition, it is not fit. Usually it has uh, good prognosis. You need to take certain measures like plenty of fluid, don't stand up for a longer period of time. If you have to stand up, if you have to do something in which you have to stand up, take breaks in between, try to have a rest, sit down, move your toes regularly when you are standing so that the blood may not accumulate. You can also offer certain pressure stockings so that to avoid the pooling. Anyways, you can refer the patient to physiotherapist. What he will do, he will teach him calf strengthening exercises. He will strengthen his calf muscles and lower tummy because, as I told you, the problem occurs due to the pooling of blood in the legs. So when the muscles of calf will be strengthened, there will be no pooling or less pooling. So physiotherapy can help a bit. If someone is having very devastating syncopes, you can add on fludrocortisone. Fludrocortisone is a volume expander, so it can help a bit in preventing further attacks. Okay, some books suggest that beta blockers and SSRIs in some trials, but not so successful. So mostly reassurance, physiotherapy, fludrocortisone are the things we need to tell the patient. Okay, so this was vasovagal syncope. Tilt
Sir,
table test, just give me a second. Tilt table test, we don't do routinely, but uh, if we have to do the tilt table test, how we will do that? We will make the patient lie down supine, pad him, attach pads to him. Then we will measure his vitals. Then we will tilt the table head up and legs down for 45 minutes at 60 to 70 degrees angle. 60 to 70 degrees angle. Then we will measure blood pressure and ECG. If patients develop bradycardia, hypotension, it means that there is some problem with autonomic regulation and he may have syncope. Okay. Uh, there are certain red flags you must know in the syncope. If you find any history of sudden onset, syncope of sudden onset, fainting of sudden onset at exertion, significant chest pain, dyspnea, raising of heart, or if you find any focal neurological deficit, if the age of onset is more than 60, okay, these are the red flags. It means that you might not be dealing with vasovagal syncope. You might be having something else. Usually, there's no need to admit the patient, uh, but if you have certain confusing factors, confusing things in the history, or if the history shows any red flags, you can proceed with echo and whatever you think. But generally, vasovagal syncope, no need to admit, no need to do detailed cardiac investigations like echo and whatever. This was what the triggers can be fatigue, uh, hunger, warm weather, pain, fear, apprehension, long standing. They all can be the triggers for syncopal attack. So this was vasovagal syncope. Yes, Dr. Shaheen.
yes, sir. Regarding hobbies, if patient is swimmer, will I advise to stop for
Yes,
vasovagal?
yes. As I told you, if someone is having aggressive hobbies, it is wise not to do. Okay, because exertion itself can provoke syncope, and
Vasovagal.
and especially and more importantly, it becomes more important if you have sudden death history. I mean, if the patient is having cardiac issues, then definitely he will not swim. But
Yes, sir.
if the
For all the sudden cardiac causes like Ockham and Brugada, we stop. But for vasovagal, I haven't like heard, so that's why I'm confirming.
no problem. If someone is having any hobby which can make him tired or make him fatigued, so you can advise that better to avoid those strenuous or tough exercises because it may trigger syncope.
Right,
It
sir.
is not usually so harmful, but to be on the safer side,
Yes, sir.
because if he falls down and injure himself, then definitely
And
it
sir,
can cause
regarding
problem.
yes, sir. And regarding DVL also, we will say that till the investigations are done, you should stop driving and inform DVLA. Is no
No,
time limit?
no. If the as I mentioned that if the patient is having type 1 license, right, that is his own personal car, he can drive. He has no contraindication to stop driving. He will carry on driving. Stu will
Okay,
not tell anything.
okay,
If
sir.
patient is having type 2 license, then he will stop driving.
Okay, sir. Thank you, sir. Very nice
You're
explanation.
welcome.
Thank you, sir.
There are welcome. You're there. If you read the DVLA guidelines, there are different syncope at rest. I mean, syncope at lying down flat, syncope at sitting, syncope in sleep. I mean, so many things, and they have different guidelines for them. But for exam purpose, the most common syncope we get because the complicated syncope, like syncope at lying down flat, syncope at sleep, this is not our game. This is maybe not beyond the scope of PACES. So for us, syncope is standing when the patient is standing. For this syncope at standing, type 1 license, he can drive. Type 2 license, he needs to tell the DVLA. Right?
Yes, sir. Thank you so much.
You're welcome, Dr. Shine. But to keep the introduction short so that you can save that time and
Yes.
do your things. Because if this was a lady, this is a man, Albert. If this was a lady, you need to ask pills, pregnancy, periods. That will take more time. So keep
Yes.
the introduction short and keep the questions closed-ended. In session 5, closed-ended question. I mean, yes, no questions. So may I know that before the attack, do you have had any sweating? Like yes, no. Any racing of heart? Yes, no. Any abnormal smells you have? Yes, no. So no need to make a large sentences or beautiful sentences. Just simple yes, no questions. So I think we can take the next case. Uh, Dr. Osama, are you with us? Dr. Osama?
طب انا عايز حضرتك يعني بعد ما نظبط الدنيا
Yes, doctor.
شويه
Yeah.
كده اهوت
Are
Yeah.
you here?
Yes, I'm here. Thank you.
Okay, so this is your case. I think we can see the chat in the end. Let's do the second case, then we can see. Take your time, Dr. Osama.
Okay.
All right, Dr. Osama, are you ready?
Yes, doctor. Yes, doctor.
So one, two, three, and start.
Hello, my name is Dr. Nawar, one of the physicians today in the clinic. May I confirm that I'm talking to Mrs. Kathy, 34 years?
Yes, doctor, I am.
Mrs. Kathy, we are here to take history and examine you. Is that okay with you?
Okay, doctor, thank you for your time.
Yes. Could you tell me more about your lack of activity? So what do you mean by fatigue? I mean,
Yes, doctor. Doctor, this started, I should say, 6 months ago,
mhm.
and I have fatigue more. It's getting worse day by day, and it's not improving, and I'm really worried.
Yeah, be sure. Yes, no worries. So this is start 6 months, and do you find that it is getting worse over this time?
Yeah, it is
Yeah.
getting worse.
Okay, and do you find it increase more at the end of the day, or it's all through the day?
Yes, doctor. Really, it is more in the end of the day. Yeah, not
Mm,
necessarily, but overall.
yeah. So have you noticed along with that any droopy eyelids?
Yes, doctor. My husband was telling me that I do have some droopy eyelids. Yeah,
Mm-hmm. And does it involve both eyes or one eye?
both eyes, doctor.
Yeah. And along with that, have you noticed any difficulty in combing hairs or climbing stairs?
Yes, doctor. Really, I feel
Mm,
difficulty in combing hairs.
mhm.
Mostly, you're right.
Any change in the voice tone?
Yeah, doctor. My voice has become husky.
Uh-huh. And any problem with the swallowing?
No, doctor. Not so often.
Okay. And any difficulty in breathing, especially in exertion or?
Yes, doctor. Really, I'm feeling. I have some difficulty breathing. I'm
Mhm.
feeling a short of breath. Yeah.
Yeah. And since when this has started exactly?
It started from today morning.
Okay. So along with that, any sense of choking or cough?
No, doctor.
Uh-huh. Okay. So any dizzy spells when standing from sitting position?
No, doctor.
Hmm. Okay. So along with that, have you noticed any change in your water work regarding
No,
amount,
doctor.
frequency?
No, doctor.
Mm-hmm. Any neck swellings?
No.
Okay. Any weather preferences have you noticed?
No, doctor.
Okay. Let me ask you some questions. Have you noticed any change in the weight recently?
No, doctor. My weight is constant.
Mm-hmm. Any night sweats or raising body temperature?
No, doctor.
Okay. Perfect. So may I know, do you have any joint pains or back pains along with that?
No, doctor. I have no joint pain or no backache.
Okay. Do you have any past illness of note I should be aware of?
Yes, doctor. I got some burning maturation 4 or 5 days ago. Otherwise,
Mm-hmm.
I'm fine.
Yeah. And what did you take for this burning problems in water
My
work?
my GP gave me ciprofloxacin. I take one tablet a day.
Yes. And for how long did you use this tablet?
He told me take it for 7 days at least. Today is the third or fourth day.
Yes. Have you noticed these symptoms of getting worse with this medication?
I think so, doctor, but I haven't noticed.
Okay. So apart from that, are you on over-the-counter medication?
No,
Any herbal medications?
no,
Any drug allergies?
no.
Okay. Do you have any family history of note?
Yes, my mother is diabetic. Otherwise, everyone is fine.
Okay. And any disease similar to that? Any symptoms similar to
Mm,
that in your family?
no, no,
Okay.
doctor.
Okay. So do you drive?
Yes, doctor, I have my own car.
Yes, I advise you to stop the driving for the moment till we reach definite diagnosis. Okay.
Okay, okay, fine.
And apart from that, may I examine you while we are talking? So I will
You
start
sure?
general.
What do you want to see?
Yes, so first of all, I have a general look on the patient, and I will go
Hmm.
to assessing first of all. Okay, so could you stretch your hand in front of me, please, and
Okay.
just thumb the palm to the ceiling and close your eyes, just looking for any neurological problem associated with that.
So
Then
yeah,
I
so the patient will get tosses, and the patient may get one arm weak. Yeah.
yes, and then I will assessing the pulse and asking to measure blood pressure sitting and standing.
Okay, they're normal.
And then I will examine for proximal myopathy. Just to bring
How?
sign, I will ask the patient to do a wing side, wing posture, and
Okay.
don't let me push down. And I ask
Good.
the
Good.
patient to stand from sitting position while the arms are in front of the chest.
Okay, so you want to demonstrate the weakness, right?
Yes, yeah,
Fatigability. Okay, so you'll find fatigability. Okay.
yes. Ask the patient to look to the ceiling, and now I will ask her to raise her arm up and count from 20 to backwards. Just count
Okay.
That's fine.
So
I'm looking for them.
the voice will become husky.
Yes. And then I will go to examine. Do you have any problem in your vision now?
No, doctor, my vision is fine. I do have some problem in the end of the day.
Okay, so I will just examine the eye movements, okay, the head shape. So if you feel any double vision, any double vision or discomfort, let me know. I will assessing
No,
the head shape
she
movement.
is fine. She is fine at the
Okay.
moment.
And I will, is there any tools is obvious now?
No, but
Okay.
on fatigability, you can do fatigability and she can get tosses.
Okay, then I will go to examine now the neck, if there's any swelling in the neck.
Why?
If there's association of thyroid as an autoimmune disorder, or if there is a thymoma, I would expect
Very
there
good.
is.
So you may find a thymectomy scar most commonly. Okay, so you have 1 more minute, Dr. Osama.
Yes, so I would ask, okay, then I would go to, do you smoke?
No.
And what about alcohol?
No.
That's good. And may I know what's your concern?
Doctor, why this happened to me? What is happening?
So most probably you have got a worsening of your myasthenic crisis. What we mean by myasthenic crisis is a worsening of the symptoms related to disorder called myasthenia, in which there is misdirected immune system, okay? And this results in weakness of the muscles that involve many parts of your body. Mostly this worsening of the symptoms related to the new medication that you have been on because of your burning water work. For that, we need to stop the medication. We need to admit you, and we will do some blood test and make sure about the strength of your breathing muscles. And then in another follow-up, we may need to give a medications also through your blood channels. And along with that, we will address the results of this blood test in another follow-up meeting with you.
Okay, Dr. Osama, very well. You picked the diagnosis, and I think you did well. So, what is your diagnosis?
Dr. Tanzi, most probably the patient does have, in view of the previous scar of thymectomy, she has got a myasthenic crisis related to the new medication, the ciprofloxacin that started for her urinary tract infection.
Okay, very good. Okay, so how are you going to investigate?
So first of all, I need I need to admit the patient, and I will do some basic blood test and assessing the pulmonary function test, assessing chest expansion, the forced vital capacity of the patient, and along with that, this is the main investigations I would do.
Okay.
And beside that, I may need to do chest X-ray.
Okay, so considering that you got an idea that this lady is having myasthenia from the past, so you can omit antibodies level and all these things. Not a big deal. Okay. Anyways, how are you going to manage?
So the management first, non-pharmacological education, counseling of the patient about the nature of the illness, and stop the medication urgently, the ciprofloxacin. Try to provide a suitable one for her condition. And apart from that, arrange for multidisciplinary team, including a nerve doctor and physiotherapist. And then medication-wise, so for myasthenic crisis, we have to make sure there is no fatigability of the respiratory muscles. And we may need to give a pyridostigmine along with IVIG.
Okay, good.
So,
please
plasmapheresis would be on the best option here also.
Yes, you're right. So very well done, Dr. Osama, very well done. But there are a few things. I think you did good and you covered most of the things. But
thank you.
You're welcome. But please remember that fatigue is a vague symptom. Whenever we have fatigue, so ask clearly, what do you mean by fatigue? Okay, you mean the low energy, or you mean the weakness, or fatigue is in the whole body or in a specific part of the body? Maybe you ask these things, I couldn't, or maybe the lady told herself. Anyways, please remember, okay, you have to specify and localize what do you mean by fatigue, and it is the whole body and or specific part of the body.
Yeah.
And Otherwise, I think you did well. When you have my okay, no need to ask about over-the-counter medication in session 5. No need to ask about herbal medication. No need to ask about any allergies if not required. I mean, allergies are important in shortness of breath or in cough, but in myasthenia, you can omit because time is less. And I think you were asking about constitutional symptoms. Maybe you're trying to rule out Lambert-Eaton by
Yes.
asking constitutional symptoms. Before ruling out Lambert-Eaton, um, okay, we will discuss. But anyways, you can avoid these things: over-the-counter, herbal medication, drug allergies. And when the patient tells you, do you have any family histories? Then no need to ask any history of similar disease. I mean, it means the same thing. So by doing this, you can save your time, and you can do a more focused examination, and you can add on few new things in your history.
Yeah.
So this is okay. So whenever you have myasthenia, whenever you have fatigability, weakness, which is fatigue, which is diurnal, I mean off and on weakness. So very few diseases can cause it. Myasthenia, definitely the most common, most important. So when you get a hint that this lady might be having myasthenia, you should at least do some things. Number one, and I think you did it. Ask about bulbar. The things you have done it. So please omit it. Okay, no, I'm just giving a generalized discussion. Okay, don't mind.
No,
So
thank you.
okay, yeah. So bulbar involvement is important. When you get myasthenia gravis, you ask about bulbar symptoms like difficulty in swallowing, chewing, any speech issues, um, or any shortness of breath. Okay, the bulbar involvement. Then second thing is the breathing problem, any shortness of breath, because we are worrying about the crisis. So we need to ask about breathlessness. Third thing, we can ask about autonomic features. I mean, these constitutional symptoms, maybe they can also help us in LEMS, but autonomic features can also help us to rule out Lambert-Eaton myasthenic syndrome. We can ask about like dry mouth, constipation, nocturnal diarrhea, urinary, I mean, depending on the time, urinary retention. So the fourth thing we need to do, and I think Dr. Osama were very right, to rule out few other autoimmune diseases, because myasthenia is an autoimmune disease. So when we have one disease, we can have another autoimmune disease. So we should rule out few others. And I think the most important thing, we should explore some other symptoms of myasthenia, like do you have any drooping of the eyelids? Do you have any hoarseness of the voice when you speak for a longer period of time? Do you have any difficulty combing or difficulty standing from sitting position? Or sometimes people may give history that they look depressed in the evenings. Their partner may say that you looked gloomy or depressed in the evenings. So these 3 4 things, just 1 or 2 questions or 3 questions we can ask. And now a few things are important, like because in session 5 we are not worrying about DD. If the things are clear, then move on to associations and complications. But if you are confused, then definitely Lambert-Eaton can be a DD. And as I told you, autonomic involvement and constitutional symptoms, you can ask a few questions of these. Otherwise, if you are sure that it is myasthenia, so ask about bulbar involvement, ask about breathing issues, ask about other autoimmune diseases, ask about symptoms of myasthenia. In the end, if you have time, ask about autonomic features and constitutional symptoms. You can ask 1 or 2 questions or 3 if you have time. Driving is very important. Medicine, past medical history, and the medicine which she is taking. Some medications, they can worsen the myasthenia, like this lady was taking as ciprofloxacin, it can worsen. A few others which can worsen the myasthenia, like you may have aminoglycosides. Okay, you may have clindamycin, phenothiazines, and chlorpromazine, antimalarials. I think chloroquine, the lidocaine, diazepam, uh, penicillins. Okay, and beta blockers and calcium channel blockers. They can also worsen the myasthenia. So be careful. If you find any trigger, you need to address it and stop. Mention the patient to stop it, so that if you will not, you may lose marks in the judgment. So very important. Then driving is important. Overall, for academic purpose, please remember that patients who have myasthenia, they can drive. I mean, don't tell this to the examiner, just for academic purpose. If you read the DVLA guidelines, until and unless they can keep themselves safe, I mean, with special protocols, like they should wear sunglasses, and when they are driving and they feel that their eyes are getting weak, they are getting double, or they are getting fatigued, so they must stop driving, take rest, or seek medical advice. But for our purpose, please remember, every newly diagnosed neurological disorder, either it is Parkinson, or it is myasthenia, or it is MS, multiple sclerosis, any new diagnosed neurological disorder, we must advise the patient to stop driving and inform DVLA. They will decide he is fit or not. Because as I told you, people of myasthenia can drive, but we are not eligible to take this decision. DVLA will take this decision. Okay, so you must advise her to stop driving. So, job and impact. Always ask about job and impact. And investigation. Now, examination. Basically, you have to do few things in myasthenia. Number one is you have to look at the face. You have to look at the eyes. Drooping of the eye, you can make an H if you have time, but overall drooping of the eyelids, ptosis. You can ask the patient to smile for you, to look for myasthenic snarl. Okay, they have a typical smile. You can check the neck for scar mark, thymectomy scar. Myasthenia is most often or may be related to thymoma, so you must be careful. Then you have to demarcate the weakness, the fatigability. How? You can do many things, but the presenting complaint in this case is fatigue. So you can start with any way. You can start with the arms, ask the patient to abduct the shoulders and try to push him down. Then again ask him to beat his, like birds, they beat their wing. So abduct, adduct one arm, abduct, adduct, abduct, like this 20 times or 15 times. Then again compare the power in both. The one which she has used will be weaker. So this will elaborate fatigability. You can also ask the patient to look at the ceiling, raise the head, raise the arms above the head, and look at the ceiling, and or count from 100 to 1. So gradually his voice will become husky. Her voice will become husky. Her eyelids will drop, and her arms will start coming down, they will become weaker. Anyways, some people also say, ask the patient to say ah or e. It will become husky gradually. And these are the 2-3 things you can do. You can ask the patient to count from like 1 to 100 in a single breath, like 1 to 100 without taking a breath. So first he will take a breath at, for example, 40. The next time you will ask and he will take a breath at 30. The next time he will do it, take a breath at 20. So gradually his counting will be less. So which means fatigability. And you can also mention the examiner, very important, because this lady is having, you see 95%, saturation is 95 or 96%. It is 96%. So you can also ask the examiner that you would like to do the forced vital capacity. You would like to measure it because ladies may be having crisis. So we can offer. And so this is the examination steps we can do. Some things we can do and something we can offer the examiner. Overall, the sensations and the tendon reflexes are normal in myasthenia, but please remember the reflexes may diminish or may become absent if you will repeatedly do them, right? So this was examination. And investigations, you mentioned all. I think this lady is already diagnosed, but if a new diagnosed case, newly diagnosed, we can do anticholinesterase antibodies, anti-musk antibodies. We can also do the other autoimmune profile, chest X-ray or CT for thymoma. Then repetitive nerve stimulation, which will show decremental response, okay? And single fiber electromyography, and of course the very famous adrophonium or tensilon test. Very famous question in exam: what is the bedside test? Any bedside test for myasthenia? So there is one test known as ice pack test. Ice pack. Myasthenia has a tendency to get better in cold weather. So if the patient has ptosis, you can put blocks of ice, I mean, for some seconds, 10 seconds or some time. So the ptosis will be better, will become better. So it is known as ice pack test, and you can do it on the bedside. Treatment, definitely this lady is for admission, and crisis is there, suspicion of crisis. So we can do plasmapheresis or IVIG, whatever is suitable, consultant opinion. But overall, for myasthenia, we need to do anticholinesterase inhibitors, pyridostigmine, neostigmine. We may use steroids in refractory cases. Steroids have a paradoxical effect. I mean, if you start steroids, low dose prednisolone, it will worsen myasthenia for 2 weeks, 1 or 2 weeks. Then the symptoms will start improving. So prednisolone has a paradoxical effect. Definitely, thymectomy we can do. Please remember that if we do thymectomy, it may take 3 years for symptoms to regress. So quite a long wait, even after thymectomy. Nowadays, they are trying to do some autologous stem cell transplantation to treat myasthenia, but it is still experimental. All right, there is one special myasthenia type known as ocular myasthenia, in which you will find the symptoms in the eye only. No symptoms, only symptoms in the eye. I mean, ptosis, diplopia, whatever. So this anti-musk antibody is more specific for ocular myasthenia. And for ocular myasthenia, you may give 3,4 diaminopyridine. Okay. But please remember that within a couple of years, approximately all ocular myasthenia will become general myasthenia. I mean, so overall things are like this. And myasthenia, basically the fatigability, fluctuation of weakness, this is the hallmark. And thymoma is associated with, I think, 15 to 20% of people. Triggers are very important. Never miss the triggers, like warm weather, recurrent viral illness, recent viral illness, steroids, pregnancy can worsen myasthenia. Okay, And if someone has any underlying disease like chronic renal problem or heart problem, worsening of those chronic problems will result worsening of myasthenia. And drugs I told you, I will repeat: quinolones, aminoglycosides, clindamycin, phenothiazine, chlorpromazine, and penicillins, antimalarial, beta blockers, they all can worsen myasthenia. So pregnancy is very important because myasthenia has a tendency to get worsened. Overall, I think this was myasthenia, and very important case. Both of the cases we did are very important. I think we can't have any exam diet in which these cases are not discussed. So very important. So Dr. MD, yes, you have any question? Have raised the hand. MD stands for Muhammad, I think, Dr. Muhammad.
No, very thank you, Dr. Danzi.
You're welcome. You're welcome, Dr. Osam. You're welcome.
Sir, I have a question.
Yes, sure, please.
Sir, you mentioned that in case of myasthenia gravis, it is not that important to exclude Lambert-Eaton myasthenic syndrome. Is it true for every single station 5 that we do not go through the differential
Listen,
diagnosis question?
No, I told you that session 5 is a game of diagnosis and association of the diagnosis. Okay, so if you are sure, if you get a diagnosis, then definitely you should go on and rule out the associations and complications. But definitely, if we are stuck and we don't know the diagnosis, we couldn't get the diagnosis, then at least we should give a DD. DD is always there to save us. But mostly in session 5, no need to mention the differential diagnosis. Try to find out the diagnosis, and mostly the diagnosis is clear.
Okay,
In
sir.
session 2, we need to give a differential diagnosis. Okay, but in session 5, we need to pick up the diagnosis, and if we have the diagnosis, then go for the associations and complications. Like if someone has weight gain, so definitely you will probe the weight gain, and definitely you will ask few questions in the beginning. Obviously, it will be clear. Weight gain is quite a clear thing. You will see the patient and you will get an idea. So if you think it is Cushing, then you should go for in the direction of Cushing. Ask about associations and complications of Cushing, and there are a few things we should ask in the Cushing. So ask those things. If you are done with those things, then you may ask about hypothyroidism, other DD, I mean for DD questions, okay? But more important is associations and complications. This is what we need. If you are done with associations and complications, sure, if you have time, ask questions about DD, no problem. But DD is not priority in station 5. But if we don't know the diagnosis, if we are stuck, that is another issue. We need to then find out a DD at least.
Thank you, sir. One more, please.
Sure.
Okay, sir. If smoking and alcohol history is not important in my diagnosis, should I still ask them?
Yes, this is a big problem. Smoking, alcohol, and job. This is something we can't omit. Even in session 4. Okay, and 3 P's: pills, period, pregnancy, pills, period, pregnancy in female. So these two things we can't forget. We have to ask. And smoking, you cannot ask until you advise to quit. There is no advantage of asking smoking until you advise him to quit. So both things are same: smoking and quitting, alcohol, job, and impact. You can't ask about job until you ask about impact of the disease. So they are pairs. So we have to ask them. And 3 P's in ladies, childbearing age, period, pill, pregnancy. We have to ask them.
Okay, sir. Thank you.
Okay, so let us have some. Yes, sir. Yes, doctor.
So this should we ask if the patient is diagnosed of any condition early on, meaning it's his own case of maybe some myasthenia gravis which is already diagnosed, and now Because now she has
Yes.
come with some precipitating event, no, sir, which is urine infection and ciprofloxacin, which has precipitated the
Yes.
event. Maybe she's already a known case of myasthenia, and this is worsened. Urine infection has worsened the condition.
Yes, this is very important, doctor. Really, I'm really thankful. But this is quite basic thing. I think we have discussed it many times. In station 5, two things you should take care. One is whatever you can see, you should see in the very beginning. In station 2, you are not allowed to see the patient, so you can't see. For example, someone has rash, someone has joint pain, someone has swelling, so you can see in station 5. So when you go enter the station, hello, hi, I'm this, and I'm here to examine. And how, what brings you to the hospital? I'm sorry, just I have pain in my neck, or I have pain in my hand. Can I see your hand, please? Immediately see, and then you proceed on location, on set, quality. So you see what you can see it in the beginning. It will make your life easy. And this past medical history, so usually I suggest that you ask 3 histories in session 5. Number 1, family history. Number 2, past medical history. Number 3, any history of medication. These are the 3 histories. In session 2, we ask about allergies, hospitalization, surgery, many things, travel. But in session 5, ask about family history, past medical condition history, and medication history. And this past medical history, bring it early. After doing history of pathologic complaint, ask the patient, do you have any other past medical condition I should know about? Okay. So like, for example, there has been a case when patient was having headache. So the candidate, she's in UK now, working there. So she told me that she asked, do you have any other medical condition? So the surrogate told, yes, I have acromegaly and I was operated for it. So the case become easy. It was basically recurrence of the adenoma. So if you ask past medical history early, that will make your life easy and you may get important clues. But not in station 2. In station 2, if you will ask this question earlier on, they will say, doctor, what do you want to know? Please ask, what do you want to know? They will not tell. In station 5, if you remember, bring it early and they will tell you. And this is especially very important when you don't have spot diagnosis. I mean, if you have a spot diagnosis like SLE, like scleroderma, it is clear, you see the patient and you can get it. But when you have some case like chest pain, like headaches, like shortness of breath, so in that cases where you don't have spot diagnosis, if you ask past medical history earlier on, you may get important clues and your life may become easy. Very important. Is it clear, doctor?
Yes, sir. Thank you. Thank you very much.
You are welcome. So let us see the chat. Is it, if we do not know it is cannot happen? Well, please remember that in young patients who has fainting, we will still rule out cardiovascular causes. And yes, it can be dangerous. That is why when you palpate carotids, never feel both carotids at same time. There are baroreceptors, they can be triggered. So always feel one carotid at a time, especially in older people. Okay. So this is very important. Always mention single carotid at a single time, but you have to feel carotids. Okay. Other questions like steroids. Steroids we will not use in pregnancy. I think really there's no problem with steroids in pregnancy, Dr. Naseem Al-Huda. At least if someone can comment. For me, I think there's no problem with steroids in pregnancy. We can use them.
No, doctor, I did not ask about pregnancy. It's about emergency in myasthenia gravis.
Oh, sorry, I made I misread it.
or no?
No problem. No, doctor, really. In crisis, no. In
Yes.
crisis, you will go for plasmapheresis or IVIG.
Okay.
Sir, for painting, we will do carotid Doppler investigation mention or not?
Dr. Shaheen, I mentioned you that for vasovagal syncope, only do 12 lead ECG and tilt table test if the history is clear. If the history is not clear, there is family history of sudden death, or the patient gives you vague history, then you may add on echo. If the patient gives you history of arrhythmias, racing of the heart, you may add on Holter monitoring, cardiac monitoring, whatever, but not for syncope, vasovagal syncope.
Okay, sir, thank you.
And for crisis, what examination we do? Mostly, we will focus on the breathing. We will tell the examiner that I would like to measure the vital capacity, bedside vital capacity. And this is the only thing we need to add on. Overall, I mean, in myasthenia, whenever you examine, always mention vital capacity bedside. There is no specific other examination we can do in myasthenia crisis. We will follow the routine steps, but focus more on the breathing. Is it clear, Dr. Shah? Anyways, so any other questions? Any other concerns?
Sir, just one question. Can you repeat the drugs which aggravate myasthenia?
Yes, Dr. Shaheen, I can surely repeat if I remember. This is ciprofloxacin, ciprofloxacin, aminoglycosides, and antimalarials, this chloroquine, lithium, and penicillin, phenytoin, and clindamycin, and beta blockers, and calcium channel blockers.
Okay, sir. And some antipsychotic also you said, sir? Prokinamide.
Prokinamide can cause SLE, I think.
Yes, sir.
I don't remember really. I am
Yes,
not
sir.
sure
These
about
are these are enough, sir. Thank you.
that. Okay, no problem. So if there's no other query, I think we can end the meeting.
Sir, one last question, sir.
Yeah, sure, doctor.
Okay, sir. If I don't exactly know the DVLA guideline about that specific disease, can you tell the patient that I'm not sure about this? I will check that on you and tell you the exact thing in the next meeting.
Well, personally, honestly speaking, I will say that you should avoid it. Try to learn important DVLA associations, DVLA guidelines, because it is an exam and we don't know how the examiner will see or look. So to be on the safer side, yes, definitely, if you don't know, you can't say that I don't know. You can say I don't remember at the moment. I will ask my senior. I will come back to you. But I think better to know some important guidelines, and
Yes,
because it depends upon the examiner. He may mind, and we may lose marks, which we don't want. So, but if you forget, if you don't know, definitely the last resort, say sorry and say I will come back to you. What can we do?
Okay, sir. Thank you. Sir.
So overall, try to pick up the things, try to get the clues. The more prompt, I mean, the more hints you need, chances are the more marks you lose, because definitely it is exam and examiners may mind that this guy is he needs more hints or prompting, so it is better to read some guidelines. Okay. Anyways, there's one more. Okay, so I think thank you very much for joining. Tomorrow I will share the recording.